Hey everyone, and welcome to this episode of Office Hours. I'm Stuart Newsom, and today's session is titled Lab Revolution in the Age of AI and Access. I'm joined by Ashish Dua, who's the president and co-founder of Glidian, who recently just joined the Infinix family. Hey Ashish, how you doing today?
I'm doing well, thank you. It's great to be part of the Infinix family. Yeah, we're a company that started very heavily in the lab space around prior authorizations, and I think it's been a great opportunity to expand our offering beyond just what we started in lab and prior auth.
Awesome, awesome. Yeah, and I know that probably throughout the sequence of this session, we'll probably get a little deeper dive into what drove you, to start Glydian. As you are a co-founder, and it was a very personal problem. I know, and I'm probably getting ahead here,
Mhm.
what we're going to talk about, but so glad that you and your team have joined our crew, and they're just an amazing team. I can't say enough about them and the interactions that I've had with them. They're all just great. So with that said, I want to give it a little backdrop. Today we are going to talk about how AI and automation are helping labs scale smarter. It's all about smarter, not harder, in the work ethic streamline. But we're also going to look at how we can streamline the access and prior authorizations and turn diagnostics into true revenue engine instead of a cost center. So as always, we're going to have a Q&A session at the end. So please drop your questions for us so we can get to those at the end. And if you have comments, I always ask people to drop comments. It's not just about questions. If you have any insights, if you have any suggestions, whatever the case may be, the floor is totally open. We'll listen. So with that, Ashish, we'll dive right in to the first question. So you've worked with both early stage and high volume labs. So what challenges are they facing when it comes to managing access and prior authorization, particularly at scale?
Right, right. So I think there's roughly the problems that labs have in the prior authorization space can be broken into understanding the clinical side of the prior authorization and then streamlining your processes to handle those prior authorizations. So labs that are just starting out often have more problems with understanding the clinical criteria they need per payer. They may have newer tests, novel tests that payers may or may not cover. So it's very critical for them to understand that when they're sending these prior auths, what set of information should they be sending? And then as they begin to scale and become high volume labs, they have to really streamline their processes so that they're not simply just adding more FTEs as their volume grows. That's just not a sustainable model. And that's really where we felt there was an opportunity here of not only can we help early stage labs understand payer criteria specific to the payer, because every payer will have its own set of criteria, but also as the volume begins to scale, they're able to use far fewer FTEs to manage the process. So as an example, an average FTE might be able to handle 24 authorizations a day in terms of submitting and following up of what they've already submitted. We can supercharge that FTE to handling more than 100 a day. So that's really where the Glydian becomes a one-stop shop solution for any lab, early or late stage.
Right. And just to kind of spin off that before we go to the next question, I know staffing has always been a continuous problem. It is top of mind with a lot of administrators, a lot of CFOs, a lot of leadership in the RCM space. It seems to always resonate. There are others, but staffing also just overreaches to so many other areas, prior auth being one. And I know that what you've just stated, talking about, taking this to scale, instead of the plan being expand your FTEs, we really don't have to do that if you can put in or implement a solution or a game plan that such as Glydian brings. So
Yep.
that's amazing.
Exactly, and I think quick thing there is that you want your FTEs doing high value work. You don't want them sitting on the phone waiting for Blue Cross Blue Shield to pick up the phone. So it's really reallocating that staff to high value work and supercharging them, as I've said before.
Right, right, right. So now the way that work's done essentially is AI is all the buzz, and it
Right.
always has been. And I think pretty much our audience and everyone I speak to now realizes unlike before where you would say AI and people would just gravitate to it and say, okay, yeah, we need that. But now they're asking, okay, well, what do you mean when you say AI? And how are you using it? So how is Glidian using AI today? And what are some of the most promising developments on the horizon in lab automation, particularly?
Yeah, so we actually started putting some pretty significant effort into AI last year, and the acquisition by Infinix will really let us accelerate that AI work that we're doing. The three areas of focus that are important to us are first, using AI to be able to understand payer criteria, and at the point of submitting an authorization, you would be able to tell, are you missing critical pieces of data? Give warning flags that without this documentation, it is very unlikely that you will get an authorization. So doing a pre-check. That really cuts down on the back and forth you would deal with a payer if they were to come back and ask for additional information, or worse, just give you a denial that you have to go and appeal now. Second is automating all the back and forth with the payers. So there are payers that are more forward thinking. We built direct connections to them. We are able to send them authorizations fully electronically, but there's still maybe manual processing involved, such as getting the letter of approval or denial may not be automated. So that's where we can start to leverage technologies like AI to not only pull those letters in, but analyze them and give succinct reasons for denial so that it becomes easier for a lab to analyze which payers are really taking the longest to give them approvals or denying them outright. And then the third area that's really exciting is being able to answer the clinical questions or flag where the clinical data is to be able to answer the clinical question. Those are the three areas that I see that AI would really begin to streamline not only the manual work, but also some of the clinical side of it as well.
Right, right. And those three areas, just any one of those alone would save tremendous amount of resources and time and build efficiency. But when you add all three of those together, it's really going to maximize and optimize, how and really rethink how labs are actually going to go about doing their prior auths, submitting those prior auths. It's obviously determination. If you don't need one, yeah, why even bother? So it's
Right.
nice to know that if you need one or not, that simple thing right there would make things so much more efficient. And then you harped on the clinical aspect, just understanding not only are clinicals likely going to be needed, because then the AI can pick up on that, right? So it could be say, hey, typically when this goes in, it's going to need some clinicals. Just go ahead and get
Right.
ready for that. So it's not a surprise. So it sounds like what this is set up and how Glidian has this handled is it's like a no surprises, so to speak.
Exactly.
So you mentioned that labs um, often need to rely on physicians to handle prior authorizations, which can cause a lot of frustration for both parties. I mean, I know there's the referring provider and the rendering provider, and I know traditionally the referring provider is typically assumed that they're the ones that are supposed to initiate that prior auth if it's needed, but then they always don't do so. And then when they do so, if they do, then they don't exactly communicate the outcomes or the status of that prior auth with the rendering provider. So in this case, the labs. So knowing that that's frustrating, how is Glidian facilitating that process, optimizing that process?
Right. So there are payers which will say that the responsibility of obtaining the prior authorization on these lab tests falls on the ordering provider. The problem being that these ordering providers are already overwhelmed with authorizations they're doing for their own procedures and for procedures they refer out, like imaging studies, lab tests. And so what we have is a provider enrollment program where we can enroll a provider into our system and we can handle more of the manual processes for that ordering provider. And we really become the glue of getting clinical information from the ordering provider, from the lab, delivering that in a packaged format to the payer, and then getting a decision back to the relevant parties. We have about 100,000 providers enrolled in this program. They're available to any one of the labs that we work with. It's a very simple enrollment process, and I think it really helps cut down on the manual work that any one of these parties have to do.
Yeah, that is so crucial. Just understanding where everyone can just be aligned in that collaboration. It's all about alignment and communication. So that definitely helps tremendously. especially with the enrollment process. So let's talk a little bit more about your physician enrollment program. How does it work? What impact has it had on lab client relationships and reimbursement success?
Yeah, so it's actually a pretty simple process. They go online, they're able to fill in some very basic information. They sign a BAA with us that we're able to handle PHI on their behalf. We become an agent for the ordering provider. The enrollment takes a few minutes online, which is why we've been able to scale so quickly, to, as I mentioned, to over 100,000 providers. And these providers, I think, see tremendous value in this, where they're still involved in the clinical aspect of providing information, which is where they're experts. And then we are involved in automating all the manual processes between us and the payer, which is where we have our technology and where our expertise lies. This really helps the lab where traditionally they would have to go back to the provider, tell them, hey, you need to handle this prior auth. Sometimes additional information is needed, and then they need to go back to the provider again, which is actually causing delays for the patient and actually increasing administrative burden for the payer as well. So this program that we have really helps payers and providers.
Wow, that's amazing. So it's almost like you're a mediator. You're kind
The
of,
glue between them all.
yeah, exactly, exactly. So say, hey, we'll come in, we'll connect the dots for everyone involved. So because at the end of the day, it's about the patient. When everyone's kind of jostling over whoever is supposed to be responsible for this or lack of communication therein, yeah, it's really cool that you're kind of like the hub, that connects, that connector, so to speak, when you're joining, two joints together. It really helps facilitate that for more efficiency. So you mentioned that AI could answer clinical questions that labs often avoid staffing for. And obviously, it's one thing to have someone in patient access on the front end that's, data entry, processing, and being on the phone, like you said, but it's a whole nother ball of wax, especially from a revenue compensation standpoint, if someone is clinical background. Those can be very
Right.
expensive hires. So can you unpack how this might reshape the role of lab RCM teams in the future?
Right. So yeah, clinical personnel are some of the most expensive personnel that a lab has to keep on staff. And we have proof of concepts of being able to answer these clinical questions provided the relevant data is given to the AI model. What I think what some labs will probably opt to do is very similar to what a computer did back in the day, where it makes your work that much simpler instead of having to go through hundreds of pages of clinical data to find out where is the relevant information to answer this clinical question. It could pinpoint you to here's the sections that you should review. Here's probably the relevant information for you to review. So it's something similar to where I brought up earlier, where a person might be doing 24 auths, they're doing 100 today, where this clinical reviewer just becomes that much more efficient. So they're still in the loop, they're still answering the questions, but the AI is there to guide them. Some labs might opt for the completely autonomous route of having AI answer the question. So
Mhm.
that we have that proof of concept, I think that's where we'll need, to start rolling this out with labs and see which way they'd like to go.
Yeah, yeah, because now you're going into the realm of medical necessity. What
Right.
does the policy say? Because I've always been a student of medical necessity, and there are different sides. There's the clinical side that yes, this is justifiable reason to perform this lab test for this patient based on the diagnosis. But then there's also payer rules, which
Hmm.
is, hey, maybe they want a less invasive lab, or maybe they just don't want to pay for that lab, whatever the reason may be. Sometimes those don't align. So now with clinical personnel and the model that you're talking about with some proof of concepts that you just mentioned, it would be helpful. The AI could take it to that level where it looks at it from both sides of that coin, so to speak.
Hmm.
Always err on the clinical side, what I call clinically defensible medical necessity,
Right.
regardless of what the payer is going to say. But yeah, the payers hold all the money, and they
Mhm.
hold all the clout, so to speak, or leverage in that. So you do have to play by their rules to a certain extent. So that's
Right.
awesome. Um, and I am going to circle back to when earlier when I was talking about how you founded the company. Just adding
Right.
one more question in here. I don't know if you could give kind of tell that story about how it was just so personal, because that's, to me, that's just a compelling story. I'm a big believer in empathy, having empathy for what providers are going through whenever you're developing a service or developing tools. If it's a vendor that just hasn't lived it, then they really won't realize the impact it will have for you. So if you could just, share that with us, that'd be great.
Yeah, absolutely. So I started this company actually in 2017 with Robert Romano. I've known him since freshman year of college, so we've known each other a very long time. We wanted to start a company around really helping patients. A surprising statistic that we found was that 2 out of 3 personal bankruptcies in the United States are due to medical debt. And when we really dug in as to what the issue is, it's because of, I would say, very broken communication between payers and providers. Prior authorizations is one of the most expensive transactions today. It actually caught our eye when my co-founder got a test done, at a hospital in the Bay Area. He was told it was completely covered, and then he got a bill in the mail asking him to pay the few $1,000s, or might have been several $1,000s for the test that he got done. Luckily, he had a voicemail from them saying that it was covered, but not everybody has that evidence. Not everybody's tech savvy, and they fall into this trap of being told that things are covered or just not getting very good estimates. So that's really where we dug in and understood, we want to fix this communication between payers and providers because that is really what trickles down to what does a patient pay and what is the estimate that they get. Prior authorization, as I mentioned, is the most manual process. So that's where we started. And, we started in 2017 and today we're processing more than 1 million authorizations a year. So really proud of what we built here.
Yeah, that's all you should be. It's very astonishing, and having that patient point of view is just so critical. I think sometimes we can lose sight, especially if you're on the business side. With
Right.
RCM professionals like myself, we don't really see the actual patient. So
Hmm.
the clinical side definitely has that empathy, but it's important to have that mindset because at the end of the day, the patient is who needs to be taken care of for sure.
Absolutely.
So we'll just turn it over right now. That's all the questions that I have. But we'll now go into our Q&A segment of the program, so to speak, and we'll see if there's any questions. I'm going to look, and we have one question, maybe two. So what's the biggest misconceptions labs have when they first start thinking about AI and automation in their revenue cycle?
Yeah, I think a big misconception, even just going beyond revenue cycle with AI, is that he's going to 100% automate everything unsupervised. That's not how we see AI being used. We really see it being used as something that will supercharge existing employees. So that example of where I gave earlier of somebody you have on staff who is clinically trained, they can use AI to be able to very quickly look through medical notes and potentially find the relevant information to make a case to the payer. The payer's rules keep getting changed or their criteria updates as well. So it would be great if you could have side by side. Here are the latest guidelines for this payer. Here is the patient's medical notes, and here's where you can tie them together to really make your case as to why this is medically necessary. That's all manual work today, and significant time spent. So I think supercharging workers is where AI will start with first.
Awesome, awesome. So, and there's one more question that I see here, and that is, if you're a lab just getting started with high complexity testing, what are the first 2 or 3 operational priorities you'd recommend that they focus on?
Yep. So I think if you're a lab that's very early stage, and I mean like you're doing, let's say, under 50 authorizations a month, it probably does make sense to start that process in-house, because you really need to understand what are the payers looking for and why are they denying your authorizations. Often this requires collaboration with a market access team where you're trying to get coverage or trying to see how can we ultimately get this appealed in the case of denial. So that payer criteria is very critical. Second is to start to set up some kind of process as to who will answer the clinical questions, divide up the clinical side of the process with the administrative side of the process. Once you really begin to scale this, that's where a vendor really makes sense when you're crossing, let's say, that 100 to 200 authorizations a month mark, where you don't want to just keep scaling volume with FTEs. You want to use some kind of system that could supercharge the superstars you've already trained internally to be able to do more with less. So
Mhm.
that's really where, if I were starting off, how I would think about
Awesome. Yeah, that's sound advice because I know it's if people want to get started, they don't know for A, where to start, and B, do I do, what's a priority? Because they want to jump in with both feet and just do everything and have it,
it. Right.
that instant gratification. But many times, yeah, that's sound advice to ramp it up gradually and set those priorities. Awesome. All right. Well, that's all for the questions. It looks like we have Ashish. So I want to thank you for joining us and taking your time to be with us today on office hours. We'll have you again for sure. So
Great.
keep your calendar open. And everyone else and enjoyed. Thank you for joining us as well. We look forward to seeing you again on next week's office hours. So thank you for being with us.
Great. Thank you, Stuart. Thank you, everyone.